Kind of my goal today was to try to get at least some of the information out there and some ideas to just get people kind of thinking maybe outside of the traditional box of what behavioral health or mental health can be and how it might apply to your practice or your model of care so that you could more better integrate or more integrate um, behavioral health and behavioral health, primary care behavioral health into your practice. So my name is Daniel Nead. I am a clinical psychologist and the director of integrated health at Malama Ikiola Health Center, which is an FQHC over on Maui. We serve about 12,000 patients a year. We're one of two FQs on Maui, the other one being Hana Health. So we cover the majority um, of the island of Maui. What I wanted to talk about today a little bit was different in kind of the concept of integrated health and integrated care, how that applies to behavioral health specifically, especially outside of traditional behavioral health settings, and ways that kind of you can use some of these ideas to think about the care that you provide and how you can perhaps include more aspects of behavioral health and mental health into the care that you're already giving. So what is integrated care exactly? It's something that has been talked about a lot over the past probably 10 or 15 years. And it kind of is this gray nebulous term a little bit. What we're talking about when we talk about integrated care, kind of in this context, is bringing medical care, mental health, and substance use sort of into one treatment plan or one treatment area. Traditionally, we've sort of seen those things all separated out, different providers doing different things with different treatment plans. But what we're seeing, and kind of I think what we all know intuitively, is that we're seeing more and more mental health and behavioral health needs showing up in really all aspects of life, whether that's our kids at school, whether that's our primary care clinics, whether that's the things that we're talking about with our friends and our family, whether that's the videos on TikTok that we're scrolling through that are telling us about all kinds of things. This is just a topic that's been coming up more and more. And as healthcare providers is something that we're getting asked more and more about, and therefore needing to find new ways to address or new ways to talk about. That certainly has been true in the past 4 or 5 years, kind of for obvious reasons. But even, looking at the needs assessment that was done most recently here in Maui County, the primary things that people that were identified as people's top concerns, some of were kind of our traditional, what we can consider traditional behavioral health things, like substance use and access to mental health care. But a lot of it was also social isolation, stress, lack of access to, in this case, housing, but other forms of care that we don't always consider as part of healthcare, but certainly impact our patients' mental and physical health. And this is part of the reason we need to start sort of addressing this, especially at a primary care level, because a lot of times we are the first access to the healthcare system for most people. And therefore we have a lot of power and a lot of ability to serve our patients better by identifying these things and then being able to provide the care that they need, whatever that care is, to help address their concerns. I don't think this will surprise anyone too much. There is a large mental health care need in Hawaii. Access to care is limited for a variety of reasons. Some of that is kind of just systemic reasons, a lack of providers, a lack of sometimes transportation even to appointments, language barriers, perhaps. There's also a lot of communities that don't access mental health for reasons of stigma and cultural belief, or mental health is not something that is part of their home culture. And so the idea that they could ask for help for something like how they're feeling or how they're sleeping or anything like that is really sort of a foreign concept. So you can see sort of from these statistics, there's a number of things going on that we're all aware of and that we're all already sort of seeing in our communities. The suicide statistic here, for instance, the state average is 16. However, in the Hawaiian and Pacific Islander community, it's 26, which is almost a 50% increase from the state average. So we can see that, there are even some communities and some peoples who are struggling even more with access to mental health care or needing access to mental health care compared to even looking at the state as a whole. And so how do we target those communities, whether they're cultural communities, whether they're age-related communities, to make sure that they are getting the care that they need that may be specific to their risk factors and to the needs that already exist for them. Going back to this idea that physical and mental health are all intertwined, for a lot of medical providers, they are already seeing a lot of mental health need in their clinics, partially because people with mental health needs also have physical health needs. People who are depressed still have diabetes. People who have schizophrenia have higher rates of tobacco use and smoking. People who smoke have higher rates of stress, which contributes to the smoking. Most of us are not getting the amount of sleep that we should be getting. And we all know that sleep has a huge impact on our mood, our thinking, our overall health. So even if you're trying to treat sort of purely from a medical standpoint and purely from a medical basis, you are already seeing a large number of mental health need existing comorbidly in your patients when they're coming simply for their physical health needs. And in primary care, this is just so especially true. There's just a huge amount of mental health or behavioral health, by which we also mean health behaviors, right? Diet, lifestyle, stress management, social contact, SDOH factors. All of these things are driving our health on top of our genetics, on top of acute injury and illness. And so whether we're aware of it or not, and whether we're prepared for it or not, there is still a large amount of mental health need that is showing up in primary care. Primary care is really the de facto mental health care system for our country. I don't know if the prison system still outdoes us number-wise, but I think at this point, primary care providers provide the vast majority of mental health care in this country, by way of sort of prescribing and counseling. So again, this is something that's already present in your exam rooms. This is something that your patients are already coming to you for help with. And what we want to do is figure out ways that we can help them with their needs when they're coming and saying, please help me. This is, I think, is one of the biggest examples that I see with people, or that I see with providers and patients, that I think we've all seen, is this like, I think I have ADHD. I took this thing online that, and I checked all of the boxes, or I saw this video on TikTok and like they just described the same, like I have these same experiences and they said they have ADHD, so maybe I do, and like could I try medication because I'm having these troubles, focusing and concentrating. And this is a hard question and hard things to tease out just in general, even for someone who has a lot of training in assessment and diagnostics and even neuropsych. This is not necessarily an easy thing to tease apart, right? Because we're looking really at two potential different causes. One would be our environmental factors, right? Which is, in this case, exposure to trauma, traumatic stress, chronic stress even, and sort of what happens from outside onto the body. And then you have kind of the ADHD model, which is saying this is a neurological disorder, usually congenital. So we're talking about kind of the brain not functioning correctly and being unable to maintain or switch attention when we want to, right? And so this is happening purely on a biological basis. And then you have this huge overlap where the symptoms of these two things are the same, and a lot of times are the symptoms that people present to primary care with. And so how do we figure out in a 20-minute or 15-minute primary care visit which of these things it is, right? Because if someone's got a trauma disorder, I don't want to be giving them stimulants. But if someone has ADHD, stimulants would be the thing that they need, right? But like, what if it's not either of these things, right? Like, there's all kinds of stuff that could be causing these symptoms as well, you know? And how do we determine which of these things that we're supposed to be treating, right? A lot of this comes down to we need some sort of interdisciplinary, integrated model for care so that we're not putting undue pressure on our medical providers to try to figure out a very complex clinical picture that most of them don't have any training in being able to actually figure out. It's pretty unfair, right? So the easiest solution then would be, well, then how do we get people to the people that can do some of the, this service and provide some of this assessment so we can figure out what next steps are. And that comes down to this age-old question, right? How do we increase access to behavioral health services and behavioral health care? I don't think there's an easy answer to this. And so part of the solution is going to be we need more people who do these things, right? We have a primary care provider shortage in this country. We have a psychiatry shortage in this country. We have all kinds of access issues purely due to the number of people who can provide that care. So if we're using that existing population, then we have to say, okay, well, then how can we get people to those providers to get the care that they need? By looking at things from a more integrated health perspective, what we start to do is move away from kind of an acute specialty care model and start looking at population health, right? Primary care is built on a population health model. It is seeing the largest number of people, right, for the smallest and least acute things. It's the strep throats, it's the sprained ankles, it's the coughs and sniffles. That's why primary care exists, right? These are things that have generally relatively, quick or easy treatment plans. It's a lot about prevention. It's catching things early. It's being able to see, again, the largest number of people for the smallest acuity of causes. And that's really the basis on which our healthcare system is built on, right? If everyone was going to the emergency room for every cough and sniffle, then the emergency room would not be very useful because it would be constantly overrun. So if we think of this population health model and we start to think of behavioral health from a population health model, what we've kind of traditionally always seen it as is this sort of individual care, right? It's one-on-one service. It's sitting down for therapy with your therapist who you see, every week or every 2 weeks. And you have this kind of very one-on-one treatment, right? That's traditionally what behavioral health has been. But if we think about that, again, from a population health model, that means that those providers' schedules get filled up very quickly, right? Because they may only be able to see 6 to 8 patients a day. But imagine if you were operating at a population health level. Imagine if that person could see 12 patients a day, right? And that's when we start to sort of look at how we can expand behavioral health into these other types of care models, right? Integrated care models where we're maybe targeting people who are at high risk to prevent problems from happening down the road, the same way we currently do, colonoscopies, and we screen for smoking, and we take people's blood pressure every time they come in. But also using kind of this making every contact count model like we do in primary care, which is every time we see the patient, we take their blood pressure, whether they're coming in for blood pressure issues or not. We take their temperature. We do their, a lot of places are starting to do like the PHQ-2 or the GAD-2 and start asking about mood as a way to say, let's just check on these things since the patient's here. And that way, if something pops, we can address it now. And we're not waiting for it to get more acute where they come in for a sick visit. And now care is going to take longer and require more resources. So it's starting to shift kind of into this population health model of behavioral health to match the population health model of medicine that we already exist in. Integrated behavioral health exists based on the biopsychosocial model of health. I think this is probably much more apparent to people now But just for some basic background, the biopsychosocial model of health says that our health is based on our biology, obviously, and the factors that are connected to our biology, but also on our psychology, right? Our mood, our behavior, our thinking, our experiences, as well as our social environment, right? Who are we around? What are we exposed to in our environment? What do we have access to? What do we not have access to? And so by putting all of these things together, we then can see sort of an overall picture of people's health and therefore a better idea of what their health needs are and therefore a better idea of what their treatment needs are. Traditionally, the medical model has looked really just at the biology, right? And behavioral health has looked just at the psychology. And social part was really not addressed much at all until much more recently with the advent of positions like community health workers. And so this idea of integrated behavioral health, right, is sort of integrating these three spheres of people's experience and people's health in order to get a better overall view of what their health and health needs are. Again, going back to this idea of primary care kind of already being the de facto mental health system, why is it that we need to sort of integrate in the ways that we do? What is it that's not working, right? We know that mental health people exist, patients can go there. Why don't we just do that, right? Why do we have to change the way that we're providing care? Because it doesn't really work very well, quite frankly. Most behavioral health referrals do not end up with the patient actually receiving services from a behavioral health provider. And even then, the mean number of visits is usually one. There's a lot of different reasons for that. Some of that is stigma. Again, going back to some communities are more aware and more willing to access kind of mental health, behavioral health services than others. Some of it is patient preference, right? They don't want to go talk to a new provider. They already know their medical provider. They already have a relationship with their medical provider. They don't want to start things over with someone new. Some of it is practical, right? Some of it is, can they get to the other office where the behavioral health provider is? Do they have money for more copays? Can they get a babysitter for their kids? Like, can they get time off work? There's all different kinds of reasons that people don't get to their specialist or that mental health referral number, or doesn't follow through very easily, or the patient isn't able to engage in care effectively.
We have a good question that
Again,
I think fits right here, and it is,
yes.
how does this intersect, or does it, with community psychology? And I think you just kind of covered that. If you can go to both, that's ideal, but maybe you can't.
Yeah, maybe you can, and I'll talk a little bit more too, but like also think of this as like, think of traditional mental health as specialty care, right? Like, we've not really had a primary care version of behavioral health ever. That's kind of a much newer thing. So imagine if the medical system modeled the way the behavioral health system is set up, right? Where everything started at the specialty care level. Imagine if everyone with strep throat had to go see infectious disease, right? Imagine if everyone who had high blood pressure had to go see cardiology. What would happen to those systems? They'd be completely overrun because all of these specialists are having to see everything from the most minute thing all the way up to something that would require like a hospital admission, right? And the mental health system kind of has always been like that because there was no primary care version. So some of it is access to specialty care, but some of it is also just the idea of, do they need specialty care, right? A lot of the patients I work with, they don't need to go see a therapist. I do consults in primary care. We talk about sleep hygiene for 20 minutes, and I say, call us back in a month and let us know how things are going. And if you're still not sleeping well, we'll have you come back in and we'll figure out what's going on and try some other things. The same thing as if someone has strep throat, we say, here's your antibiotics, take these for the next 5 days. And if your symptoms don't go away, call us. Otherwise, we'll see you next time. So it's also this idea of just reconceptualizing mental health as existing at a primary care level, that not everyone needs to go see specialty care, whether or not they have access to it or not. It may just not be useful. So the role of community psychology is that specialty care level. We absolutely need people at that level that can do the long-term work, the specialty work of, mood disorders, eating disorders, family therapy, things that require maybe a more advanced level of care due to the advanced level of acuity. But there's a lot that happens at the primary care level that patients just don't need to be referred to specialty care. We can take care of it right here today in the office with your primary care provider. I'm trying to be mindful of my time. So I think I kind of that question sort of preempted this slide a little bit, which is this idea that we tend to think um, of behavioral health as existing kind of up here in this kind of high behavioral health need, low physical health need, right? Which is what we consider traditional or specialty mental health, psychiatry, crisis services, those sorts of things. What integrated care does is it moves it down into this and says, people don't necessarily have big behavioral health needs. They might just be having, never had to break up with their boyfriend and they're just sort of sad about it, trying to get out of that rut. Or they might be a single mom of 2 kids and they're kind of stressed out and just would like to know how to manage their stress better. Or they're not sleeping well and they just want to, they're coming in maybe for medication to sleep. But, the gold standard for sleep stuff is actually behavioral change. So how do we help people get better sleep before it becomes like a more significant sleep disorder? And so this is sort of the pulling down of behavioral health from that specialty care down into primary care and saying, like, we're not going to pathologize normal life. People feel stressed, people feel sad. Grief is just depression that we expect to happen. There's no diagnostic difference between a depressive episode and grief. It's purely the context that changes that. And so if we kind of, again, zoom things out and say people exist in a context and their context affects how they feel, then people have life and we will treat life. For those of you guys that are primary care providers, how many of your patients come in with a stomach complaint or headaches or something going on and their labs are fine and their imaging is fine and you're finding no physical cause for what's going on, but they still don't feel well, right? They still don't feel well. Whether we're identifying what's going on or not, they're coming in and saying like something feels off, right? That happens a lot of times due to our mental and behavioral health, but that also happens to our mental and behavioral health. And so again, it's going back to this idea of not everything requires a specialty level of care simply because it's a mood or a behavioral health thing. I'm not going to go through this really. It's, the idea that integrated behavioral health is a team of professionals that are from different disciplines and that are looking not only at mental health and substance use, but also health behaviors, diabetes management, hypertension management, diet and exercise change, behavioral pain management, but also looking at life stressors and the related physical symptoms, or even patterns of healthcare, right? Here's when you go to the emergency room. Here's when you don't go to the emergency room. Here's how to figure out when you do need to go to the emergency room and when you can manage this at home by doing X, Y, and Z. So it's a lot of those factors. This, I think, is, and I'm trying to mind the time because I do have a hard stop at 12:30. Is this idea of kind of the integrated primary care continuum, right? So integrated primary care exists, like most things, on a continuum from minimal integration to kind of much more integrated than typical. So all the way down on the left, coordinated care, this is sort of our traditional model of care when it comes to mental health and when it comes to specialty medical care, right? You've got a specialist in a different place, in a different discipline, you make the referral, the patient goes there, they see that provider, hopefully that provider will send you a report back on what they talked about, and then the patient comes back to you to integrate that into their existing care. That's traditionally sort of the siloed version that we've seen of mental health and substance use and medical, right? It's 3 different people in 3 different places doing 3 different things with 3 different treatment plans. As we get more into the middle, you can see more co-located models. So this is where you might still have the behavioral health provider and the medical provider, and they're still doing their own things, but they might be located in the same building or even in the same clinic. And so you have this much easier exchange of referrals, easier exchange of information, You may have some system integration. You may still have separate EMRs, but you're still really seeing that sort of separate treatment plans. They're treating separate diagnoses. They're collaborating more and talking more, but they're still treating kind of two different things. And then as you get into more integrated models, what you start to get into is the patient has one team, they have one treatment plan, and that team and that treatment plan covers everything that walks in the door, whether that's mood, whether that's medical, whether that's behavior. And you have this team that's working very closely together to treat the patient. So even if they're not working at the same time, like I work with a lot of patients who have poorly controlled diabetes, because managing diabetes is mostly behavior. And the medical provider will take care of the insulin and any change that need to happen with the kind of on the prescription side of things. I take care of all of the behavioral stuff. And then over in the next room, Nadia, our nutritionist, helps with all the diet stuff. And we're the team that takes care of that. We have one treatment plan. We're all treating the same diagnosis. We're all charting in the same EMR. And kind of that's the integration of the team, right? You can imagine how much harder it would be for the patient if they saw their primary care provider here and then they'd go over here to see the behaviorist in a different place and then to go see the nutritionist a whole other place. And no one's talking to each other because no one has time to fax notes back and forth. So it really does make a big difference when you have the whole team in one place, all able to share information, all able to talk to each other, all able to see each other's notes and know what's going on. And kind of really be able to work together on a very foundational level. And so kind of shared primary care, when we're talking about that, we do have things absolutely that are specific to the medical side of things and things that are specific to the behavioral health side of things. But there are a lot of things there in the middle that we all do. So it can seem a little weird to ask a medical provider to do some behavioral health things. But really, you're probably already doing some of those things, or you have that skill set already of doing screenings and addressing symptoms and taking an HPI and following up on labs and treatment plan adherence and all of that. You're just be doing it for something different this time, right? You're screening for mood instead of screening, taking someone's blood glucose to screen for diabetes, or you're asking about how their sleep is doing instead of as well as taking their blood pressure. It's the same skill set, right? You're just kind of focused on a different presenting need or a different preventative need, depending on the patient who is sitting in front of you. So I'm sorry, it's 12:30. I have got to jump to a last minute meeting that my CEO called this morning. So
no problem. This was perfect. Can you just go back to the slide with the arrows?
That one?
Yes, that one. I love that. That's a really good representation. So you go have a good meeting, and then we'll have you back.
Yes, and I will send this to Summer. Please feel free, anyone, to reach out. You're welcome to share my email with people. I could talk about this for ages. I love this stuff. So if anyone has any questions or would like any other resources, please feel free to reach out to me. You can also Google this. There's all kinds of CMEs and CEUs related to this. It's not a secret by any means.
Yeah, and this is exciting because we also have heard about the Queen's integrated primary, let's see, now I'm going to say it wrong. But anyway, we've heard about other models, so that's good. We can talk about it. And you're very lucky, I think, and they're very lucky to have you. So go to your meeting, and thank you so much.
Yes, no problem. And I will be happy to come back at some point in the future and talk more if you'd like me to.
Perfect.
And again, anyone, please feel free to get in touch with me.
All right, great.
Okay. Thank you, everybody.
Thank you.
Thank you.
So Ricky's here to talk about Queen's Clinically Integrated Physician Network. And we've heard from Ricky before, but I just love how and I can share this. I took a picture of his scale there. But it's such a good feeling to, as a primary care provider, it's like a relief, a weight lifted to see it moving towards the right? So, yeah. Well, we got our icebreaker now. Does anybody have experience with integrated primary care? Uh-oh.
Your sound is good. I can hear you.
Okay.
Bethany,
Beth, can you?
want to exit and come back?
Yeah, that's probably the best way. And does anybody hear an echo now? We got to check on that.
No echo.
Okay, perfect. Okay. So does anybody have experience with integrated primary care? I was just so jealous hearing him. Wow, that is so cool. We did have a comment that let me read this comment, and then I think it's very pertinent. And then Ricky and Dan can talk about the QICPN. Let's see, mental health has traditionally been a part of medical care. It was only with the carve out of mental health from from medical care that created I gotta make this bigger. I'm scrolling. Okay, Dr. Weir says mental health has traditionally, in quotes, been a part of medical care. It was only with the carve out of mental health from medical care that created our current situation. I guess putting it as the specialist and kind of sending someone out to that specialist, the psychologist or whomever. Um, all right.
Helen says she has experience with it. Helen, I think you meant to message the group.
Tell us about it, Helen.
And thank you. Oh my gosh, Sean, thank you so much. And I just messaged Sean now. She's like, Sean, did you get my templates? And that's my dyslexia, just checking this. There we go. And I think it's and I'm going to be I've got a presentation in a few weeks about the idea of personhood, so I don't want to go into that at all. With the integrative care, being a UK trained nurse, National Health Service, one thing that I appreciated was we had something called partnerships in practice. So in your third year, you have to train with others of the field, your medical doctors, your specialists, your social workers, mental health nurses, midwives, everybody. So you have to get used to working together with the role of the patient in mind. How are we going to holistically, I don't really like that word too much, but how are we going to treat this person? Because we know that healthcare is like that's my baby's mobile. That's the baby's mobile. So if we've got something going on mentally, there could well be something going on physically. There could something be going on socially, economically, what's going on. So that's the idea of it, that things don't operate individually. What is my experience then? It really comes down to with working on Ireland with the smoking cessation, that we created the more integrative programs because we knew that we might need there could well be something else going on. If somebody's trying to quit smoking, well, what's the reason they're smoking in the first place? Is there some trauma? Is there other addictions going on? Is there and what are the health impacts of the smoking? We need to have that medical input. There might be prescriptions that we might need. Now that I'm just using smoking because that's my experience on Ireland, where there really was more of but that's not primary really, is it? So I've gone off on my own tangent there, but it's just that because I'm just so excited about this aspect because I think it's really needed and often overlooked. Sorry, that was that was really it when I say so there, because of my experience with the smoking cessation on Ireland. It's not exactly primary care, is it? Sorry, I went off on my own tangent there.
That's okay because he was talking about sleep. Now, discussing sleep seriously is a 15-minute conversation. So if you only have 15 minutes, that's it. You get one thing with the primary care, right? So that's very pertinent.
Well, thank you. I do have one quick comment. I noticed with working in health centres that on the primary care level, we often are given the PHQ-2. So we're checking to see if somebody has got some suicide ideation. We want to catch that. Something that I always thought was, well, we're not catching other issues that are going on. Because if the PHQ-9 is 0 on everything else, but there's not the sleep going on, or there's not the eating going on, or not feeling good about myself. There's not feeling good about myself. Is there some underlying trauma there? Are we missing a sleep? So I'm just thinking that we can miss so much very often when we're trying to cut corners.
Yeah, and the 2 is little interest or pleasure in doing things, feeling down, depressed, or hopeless. So yeah, 2 of the things. And we also had a comment that Kaiser has a lot of integration, and that's why Kaiser is such a great model across the country, that everything is often in one place. But let me turn it over to Ricky and Dan and talk about the Queen's Clinically Integrated Physician Network, because it's more for when you don't have the luxury of space and people together.
Thank you, Ricky. Ricky, do you and Brant want to also share the kind of the training experiences you've had together?
Oh, I I don't want to put Brent on the spot. If Brent wants to comment, he's definitely welcome. I got a little excited. He was one of my first MSW students, so it's just like, seeing your children out in the wild. It's just so nice. But okay, like hi Brent. Oh, really quickly, I also love that presentation because it's basically just preaching everything that we do every day. So very quickly, without kind of going into too much detail, and sorry, I only found out I was talking like an hour ago, so bear with me here. Um, what is our department's interpretation of integrated care? So that was really like a beautiful, beautiful overview of what integrated care is and can look like and why we should do it. So our answer to that is what we created at QCIPN, the Integrated Behavioral Health Collaborative Care Model. And so basically what that is that anybody within our ACO, our accountable care organization, so PCP, some specialists, they can refer to us to do our interpretation of that integrated care. I'm going to share really quick. Can I do that? Yes. Is that sharing the flyer? That's good.
Perfect.
Okay.
Yeah, I
Yeah.
can
So
see
this is
that. Thank you.
this is like our one pager that we give to our PCPs that are training with us. Like this is what it looks like, right? So medical provider, 90% of the time is going to be our PCB, right? Our ordering provider. Patients always hubbed in the center. BH care manager, that's us. So I am one of 4 social workers. Colton Arroyo is on here too. He's another one of us. We kind of have geographic pods. And then our psychiatrist consultant, of which Dan, Dr. Ali Kata, is one of ours. We have 4 now. So kind of how our model works is PCP, so kind of identifies a need for mental health, like, right? Like something comes up. For us, our clinics, a lot of them do universal standardized screeners of the full PHQ or GAD-7, PHQ-9 or GAD-7. So sometimes that's how they get referred, right? Like, oh, there was a positive screening. Can you help address this? And sometimes it's just like that, right? Or sometimes it's not even the PHQ-9 or GAD-7, but the clinical interview, patient brings it up on their own, PCP again, they're like, okay, well, it sounds like there's something going on. Do you mind if we have one of our team members call you? A social worker will call you to kind of further discuss. So again, kind of putting it in more experienced hands to kind of have that discussion with the patient, to kind of help navigate, hey, what's going on? Like I heard you talk to your PCP and kind of brought up some stuff. Could you kind of tell me a little bit about that? And then with us, because we're a little bit more experienced, we'll kind of hopefully do a very quick intake and suss it out, right? Like, is it just like sleep and just sleep alone? And yeah, is it something that just sleep hygiene and I can teach you some quick tools and then you can hopefully get improved from there? Or does it seem like there is a little bit more? Are you interested in therapy? What does that look like? And to kind of address what I think William Weir had mentioned about like it's a little less stigmatizing and scary that way, right? Like if I tell you go call a therapist and set up an appointment. For a lot of people, that's just like really overwhelming and daunting and scary. But if it's, a social worker is gonna call you and, I have that talk story, it's a lot more palatable for a lot of people, right? It's a lot of normalizing. It's a lot of, well, what do you think therapy is? And kind of readjusting what a reality of what a therapy session might look like and how it could help them. A lot of normalizing, it does sound like you're having a lot of stressors, and I think talking to someone could help you with that. If medication is indicated, that's when we hop into kind of the collaborative care model if PCP and patient are willing. So what does that even mean, right? So very generically, truncated version is that PCP sends us referral. Us, the mental health social workers, we're all licensed clinical social workers, do full biopsychosocial. And we are trained very specially alongside with our psychiatrists to do a very thorough assessment, just as the psychiatrist would. Because if I don't do a good enough assessment, psychiatrists won't feel comfortable enough to make a recommendation and or diagnosis, and then we can't provide that consultative and recommendations back to PCP and the patient. So, we have to go through a very thorough, full biopsychosocial, like Dr. Nead was saying, you're like really addressing like a lot of times, like, oh my gosh, I was just like nodding my head. Like they'll come in and they think they have ADHD, and then we do our full assessment, and it turns out it's trauma or it's just good old-fashioned anxiety. And or like they come in with depression, and so PCP will send us a referral thinking they're just looking for like a antidepressant recommendation. But then when we do our assessment, again, we're trying to like really do a full differential diagnosis. We find out, oh, this is just a depressive episode and you actually have bipolar disorder. So good thing we didn't just start you on an antidepressant without really doing that thorough assessment. Otherwise, we would have flipped you into mania, right? So that's kind of our model, right? We do that full assessment. We run it with our psychiatrists at our weekly IDT meetings. They say what they think the diagnosis is and what the medication recommendations are. And then we punt that back to PCP. We say, hey, looks like this could be some good old major depressive disorder. Maybe you want to start on an antidepressant. And usually they just give very specific recommendations. So that's like, at start sertraline, starting at 25 milligrams a day. If they're tolerating well, increase to 50 milligrams after 1 week. If they need to do baseline labs, we'll tell them that. So it kind of just really helps gear up the PCP to feel comfortable with if I am holding the bag and making medication recommendations, am I doing it thoroughly? Am I doing it well? What am I looking for as far as side effects? What am I looking for as far as, black box warnings, things like that. But then also they don't have to worry about being the only one looking for those things because the care managers call, especially if they're just starting a new medication, will call pretty frequently, like weekly, every 2 weeks. I'm like, hey, did you get started on that sertraline? How's it going? This is my favorite part, or one of my favorite parts about being a care manager, because I can have more frequent touches with the patient, and because I've already kind of hopefully established that like kind of close relationship, right? I spent a full hour up to 2 hours doing an assessment, really building rapport. Um, I can call them relatively frequently and spend the time, and they say like, oh yeah, I took one and it made me really sleepy, so I haven't taken another one. And to be able to kind of normalize that, say, well, that's a very common side effect. Like, was it to the point where it was intolerable? Or do you think you can keep taking it? Because we are looking for that side effect to subside. And really being able to handhold them through that. And then you get much better medication adherence that way because they understand like, oh, okay, that's normal. It wasn't something, and I'm looking for it to disappear. Like, yes, we're not going to see good side effects until later. And then like kind of being able to go with them on that journey and kind of do that hand holding so that hopefully we can get to a place where their medications and or therapy and everything else is going a lot better. So they are getting better. And we measure that through PHQ-9 and GAD-7. We keep taking it. We keep doing clinical interviews and things. Also, our QCIPN department is very good because, again, we don't forget the social parts, right? So I'm a social worker, but I'm not like that kind of social worker. Like if there's concerns about financial needs and things like that, I am probably just as bad as literally anybody on the street. Like, I don't know. I'm sorry, I don't know how to apply to Medicaid. Like, I just don't. But you know who does? My coworkers. So we can refer over to our coworkers and they can help with some of those psychosocial factors and or other medical components like transportation, DME, anything that can really help make sure your health and mental health care needs are all getting taken care of. I think that's kind of really quickly, generically, what our department and program does. Does anybody have any questions?
Well, people do have comments.
Mm-hmm.
Naomi says subacute units, hospice and palliative care teams tend to tend the main diagnosis in addition to all the primary care concerns of the patient. They are also discussed during IDT meetings, team meetings. Inpatient Kaiser has
Interdisciplinary team, IDT. Mm-hmm.
What is it?
Interdisciplinary team,
Of course.
IDT. Yeah.
Inpatient Kaiser has excellent IDTs, including sharing the behavioral health notes. Outpatient, there are IDTs, however, behavioral health notes are kept separate for sensitive privacy concerns and are not accessible to the main EMR unless a behavioral health provider sends the note to the non-behavioral health providers on the team. So that's kind of how Kaiser does it.
Yeah. So I think kind of going back to the point too of what Dr. Nead was saying too is that rather than like giving it to a behavioral health provider to do the medication management, we don't do any medication management. Our psychiatrists never prescribe anything. All we do is function purely in a recommendation, right? Like even if you have inpatient consult liaison, that psychiatrist is managing the psychiatrist meds. In Kaiser, I'm just guessing, but like primary care, even if they're taking into effect what behavioral health is doing, they're still staying in their lane and only managing medical stuff, and they're letting the Kaiser psychiatrists do the psychiatric meds. For us in collaborative care, we are educating and empowering and supporting the PCP to be able to manage the medications on their own because a lot of times it doesn't need behavioral health to manage it. If it's mild to moderate depression and or anxiety, that is very well managed for most people on a very simple antidepressant and or psychotherapy. We even have some bipolar patients because like they're so high functioning, have great insight and judgment, that we feel comfortable managing them through our program, right? And the PCP feels comfortable managing them through our program with additional support. Obviously, we're not meant for like super severe, and like those are the cases that should be managed directly with a behavioral health practitioner, like a direct psychiatric medication manager. But for a lot of people, for mild to moderate disorders, we can help manage that. And that is the big part of it. The PCP does have to feel comfortable managing things. And we always say, hey, we're just here as a consultative and recommendations. So this is a common factor where, again, like they come to us for depression and then we say, oh, sorry, turns out it's bipolar, you know, and so, you know, think about a mood stabilizer and antipsychotic, and PCP goes, whoa, no, because I don't like those, right? I was okay with an antidepressant, but now you're talking about too heavy hitting stuff and I don't want to touch that. And then we go, okay, fine. Let me handhold the patient then to get them that direct psychiatric services. Or
yeah, you're kind of like
because
a curbside consult for
on steroids is how our director
yeah.
likes to put it.
It's like, okay,
Yeah.
get me advice on this patient. You know, it's like magic. Like what do I do with this patient? And
Yes,
it comes back to you.
exactly. That's exactly what our department was created for. Um, PCPs already bear the brunt. And then I think, again, with when we're talking rural care, so like everybody, and even on, Oahu too, like the west side or certain like kind of healthcare deserts, as it were, or even if you live in town, if you don't have the right insurance, you're not going to be able to find a provider. And so, who is left holding the bag is the PCP. So, like, if we get stuck with it, at the very least, what we can do, if I can't get you connected to somebody else, what I can do is help support you to manage that patient, right?
Right. And so Dr. Weir says, my only negative has been difficulty getting patients to actually go to the mental health practitioners due to perceived stigma. So that's like on the far left of the diagram. And then the integrated care, you're located at the same place. You can see people together, which is super cool. But then if you don't have that option, having this magical consult happen without the doctor having to explain everything is really nice. Now, here's the kicker. Amber asks, how do you guys work the billing side of it to make time for the PCP to access your recommendations but have the time paid for?
Yeah. Y'all might hate me for this, but we don't bill for anything. And it doesn't matter what insurance you have. And I know I sound like I'm bragging, and really, I really love my job
That's
in my
okay. That's
department, so maybe I
okay.
am. Okay, so we have amazing, amazing management and directors who are much smarter than me, and I don't know how they got people to pay for it, but basically, we effectively work off contracts with payers, and we say, hey, look, we are doing you guys a service. So we work with our providers and payment transformation, right? So we're getting um, paid per patient per year versus like fee for service. So that kind of pool of money helps pay for our programs so that we don't have to worry about like specific insurances. All I have to worry about is my provider who is in my network and I'm servicing through them. I am not servicing an insurance company or anything else like that. I'm helping support my primary care provider. So we work on cost savings, not fee for service. Because if I can save an inpatient admission, if an ED visit, right? Because I helped manage their anxiety before they showed up for a panic attack. Like I'm saving so much more money for the patients and for the payers and systems that it justifies paying for our services.
And then there's a discussion about the communication in the chat. And so it sounds like both Dr. Mead and you guys, you're on the same record. You share the notes. So it makes it a lot easier. And I could even see from the case you gave of the primary care physician who sends the patient to you and thinking it was depression, but then the psychiatrist says, no, this is bipolar. And then for me, I don't use the bipolar meds with people. But if I was advised how and when to get levels drawn and what to do, I would feel much more comfortable.
Yes. Yes. Um, yeah, and we do, right? The psychiatrists are very thorough. They'll look and be like, "Oh, okay, like the last time I saw a lab done, was a while ago. You want to get a baseline to make sure that we're not worried about this, that, or the other because it does have a contraindication, right? And yeah, you get all those notices, right? Like if you're not a psychiatrist, maybe you don't know Abilify is better for mania versus like Latuda is better for like depressive bipolar. Just like little things like that, but they really help and they lay it out in their consults, and then you get a lot of case-based learning too, right? Us and the PCPs that get the consultations.
Yeah, that's true. Um, And then there was another question. Oh, the records. There's traditionally been an extra protection layer with mental health and HIV notes. So it's often harder to get those notes from Either your own EHR, if it's seeing another provider, there's often an extra barrier, or definitely when coming from a different provider. So there's a question on that. Any other comments or questions or ideas?
Ricky, can I ask a real quick question? I'm
Mhm.
seeing more and more in the emergency room where children
Oh my
are
gosh,
working
yes, us
are
too.
working with
Mm,
you, and you guys are helping them and the families transition back
mm,
into your network
Mhm.
of providers. And is that something you've always done, or is this a new development of QCIPN and its role in the ED?
So this is new. Yep, we just started our CAP program. So we've mostly been seeing adults and geriatric patients. Um, and then because we started getting child adolescent fellows with the Department of Psychiatry, and we now have a rotation with them, we've been integrating a lot more children. Um, so that is new, Dan. And a new population we've started servicing. Buy-in's been a little bit hard. I think pediatricians tend to be a little bit more hesitant with managing the mental health. And I don't necessarily blame them, but it is hard because, like, again, like psychiatry is such a shortage, like child psychiatry is like even worse, right? That subspecialty. But yeah, we do have that resource available too. Good point, Dan. Geriatric too. And we also have that resource where one of our consults is Dr. Brett Liu, who's a geriatric psychiatrist. So we are very, very, very blessed that we can handle a lot of our geriatric and dementia patients by running consults through him.
Is nice.
That's awesome. Yeah, thank you.
Other questions? Next week, by the way, Helen, you're on next week for medical Qigong. All right, cool. Because many people are concerned about the stigma of having a behavioral health diagnosis, the outpatient behavioral health record in the behavioral health department is kept. Wait, sorry, maybe I got the wrong one. Because many people are concerned about the stigma of having a behavioral health diagnosis, of having it related, et cetera, the outpatient behavioral health record is limited to the behavioral health department. Without the security, many people may not seek behavioral health support. And yeah, so this is a historical situation similar to HIV has been in the past. So it's like a separate part of the record. And who knows, in the future, it might not be an issue, but it's around now for the records. Other questions, ideas? Thank
Wait,
you.
sorry, I just remembered I'm dropping trainings for what collaborative care is. We based our model off of University of Washington Ames Center. So they do have more trainings, whether you're the PCP doing it, the psychiatrist, or if you were like in my role, the behavioral case manager, you can see what it means and more about the program. And I think you can get Cs for it too.
Cool. Okay, well, we'll see you all next week, especially you, Helen.
Let's hope so, right? Yeah, no, you will. You will. Sorry, everybody, for going off topic a little bit. I get very very passionate about the integrative healthcare model. I think it is just absolutely superb. So thank you very much for for
Yeah,
what you're doing for the guys that came in today. That's absolutely brilliant. And there's got to be a workaround with regards to the behavioral health. There just has to be. We haven't found it yet. What's one of my favorite expressions is yet.
yet.
There's always
I
a
like it.
solution. We just haven't found it yet, but there will be one. I'm
Yes.
sure. But
Well,
thank you.
thank you, everybody, and see you next week.
Thank you. Thanks, Ricky.
Thanks, Ricky.
Thank you, Ricky.
Ricky, great job. Oh, she left. Thanks, Dan.
Thanks, Kelly. Bye, everyone.